Okay, perfect. So we've split this panel up into three major topics. The first topic is social determinants of health. The next one is non-communicable diseases. And the third one is kind of COVID focused while talking about Indigenous populations' relationships with Western medicine. So for the first topic, social determinants of health, Rexine, we were wondering if you could start us off. Um, could you briefly describe the current health status of Native Americans on and off reservations, and what are the biggest challenges they face when attempting to access quality and affordable health care?
Sure, thank you so much. Firstly, I cannot speak for all 560 federally recognized tribes in the United States, but the life expectancy of Native Americans in some states is 20 years shorter than the national average. And one area that can account for this disparity is that health programs for Indigenous peoples are hugely underfunded by Congress. In addition to healthcare access being controlled and funded by the United States, the Navajo people must also manage highly toxic exploitation aided by the United States, which includes pollution from uranium mining, coal mining, and exploitive water rights arrangements, all in addition to extreme poverty due to legislative red tape that makes the economic growth feel impossible. On the Navajo Nation, 20% of roads are paved, which can delay emergency responses for hours. 1 in 3 Navajos don't have plumbing systems with running water, which can be deadly during a pandemic. And 300,000 people share 13 grocery stores that can take people 3 hours to access that food. Many people, most accessible food resource is a local gas station. So you can imagine how this can affect the management of preventable diseases. And all of this is due to the US's existential foundation in the genocidal extermination of Indigenous peoples in the United States, which continues to live on in the treatment Indigenous people receive. According to findings of a poll by NPR, the Robert Wood Johnson Foundation at Harvard T.H. Chan School of Public Health, about a quarter of Indigenous peoples reported experiencing discrimination when going to a doctor or healthcare clinic. And quite honestly, I find this number very low.
Thank you. And if anyone else, if any of the other speakers would like to add on to that answer, feel free.
I think Rexine covered a lot of things that are definitely challenges. One number that I can add to that is, in addition to the other health challenges that natives face, in the US, Native Americans also have one of the highest rates of disability among all demographics. I think the number, and I don't know if Rexine, if you have the actual number, I think it's almost 1 in 3 of Native Americans have some kind of disability. And so that's another challenge, is getting support through the healthcare systems to try to help the members of our tribes who need some additional help with mobility or medication for their disability.
Thank you. Oh yeah, Daria, go ahead.
Would you repeat the initial question again? I was processing the answers.
Yeah. So could you briefly describe the current health status of Native Americans on and off reservations? And what are the biggest challenges they face when attempting to access quality and affordable health care?
All right. Sadly, very much the same here in Canada. Healthcare access is basically, it's poor. More so for people who are on reservation, and I do work in fly-in only communities. So just imagine being on an island and not being able to go to a main city for healthcare as easily as it would be if you were from, I don't know, Kingston and going to Watertown, which is actually pretty accessible for me to go to, versus some of my patients to just for basic need, even dental care. So, I mean, yeah, accessibility, just to keep it short.
And going off of that, this is a bit more history based, but could you describe, I guess, also present day in your experience, how have you seen the United States weaponize the healthcare system against Native Americans, institutionally, or whether it be clinically on a case by case basis?
Well, I think one of the biggest things that both the US and Canada have done to weaponize healthcare against natives, and a lot of people are not aware enough of, is in sterilization. Lots of Native women would go to the hospital or a clinic and try to get some basic procedure done, or even just a checkup, and walk out without their fertility anymore. And so that's a major part of our history that's been happening up until very recently. I don't remember exactly what the years were between the US and Canada of how recent that's been, but up until the very recent 60s or 70s, I want to say, maybe even more recent than that, the government and the healthcare system has been trying to kind of sterilize Native women, believing that we can't take care of our own children, or it could be in our best interests, that kind of thing. So that's definitely the thing that jumps to mind first of all for me when I think of how the healthcare system has been weaponized.
Thank you. Does anyone else have anything to add? Rexine?
Thank you so much, Kylie. It's the whole issue with that is it's just really sad to think about. And, I think it happens still today, actually. Many of the issues that face the Navajo people include a variety of chronic illnesses due to environmental exploitation, which is possible with the assistance of the United States government. So with one hand, they control the funding of our healthcare, and with the other, they assist in environmental exploitation that perpetuates a cycle of chronic illness. For myself, I can share my own personal experience with my mother's family. My mom grew up basically in a uranium mine area. She grew up playing in the uranium mine sites, not knowing the dangers of those uranium mines. And unfortunately today, my mother has lost multiple brothers and sisters due to cancers, and just from their experience of living in those mines, or near the mines growing up. My mother is actually a survivor of breast cancer today, and she was a downwinder. So it's really sad to think about how the coal mining industry and how the uranium mining industry, the oil and gas companies, have really affected the Navajo people and their health. And especially today with COVID-19, we have a lot of Navajos that have a lot of underlying health issues. And a lot of it goes back to, the history of, those uranium mine sites or the coal mining that's on the Navajo reservation. So those have really affected the people today, so they have those underlying health issues, and, they're more susceptible to getting COVID-19 because they have health issues like COPD or just other health issues like that. So it's just a really sad situation.
Thank you so much for sharing, Rexine. Yeah, and especially here in Boston too, along the coast of Chelsea, the entire coast is just filled with like salt piles for Boston Logan Airport. It has caused a lot of underlying health conditions for the neighborhoods surrounding those salt piles, and those neighborhoods are majority Black and Hispanic. So the environmental racism has such deep roots in this country and the West in general. Sorry, Daria, you're unmuted. Did you have anything to add or no?
I suppose I could share with regard to, healthcare, the healthcare system impacting the health of Indigenous peoples here. I hate to be the face of healthcare and not have anything really positive to say with what we do. But, part of changing the system is admitting the wrongs, right? So then a terrible practice in, especially in hospitals here, is basically funneling children into, social child and family services, like, putting kids into homes and taking them away from their family. It's sort of like our healthcare system is like the new, residential schools. So that's how I feel sometimes, because, a mom will show up with her kid and be judged and separated from, have their kids taken away based on, prejudice, basically, and injustices, and just awful things that, take another talk to get into how, our Western ways are so different to Indigenous ways or non-Western ways, and that then get used to divide families and continue hurting populations in our country. And so that's ongoing. The sterilization as well, for sure. There are many women coming forward now that you can, video your medical interaction. So there's more being shared around of people, leaving the hospital and finding out that they can no longer get pregnant, never consented to those type of procedures, or a mom who from whatever records from a previous medical interaction was found to be heavily intoxicated, then that becomes a ground to then separate her from a child at birth. I have been in situations where I needed a woman evacuated quickly for post birth, and having the healthcare team delayed, but instead it's social services who shows up on reserve to take the newborn. It's like, really, like, what's the priority here? And stuff like that are still ongoing in this country as well.
Thank you so much to all three of you for sharing.
If I could add a little bit to that.
Oh yeah, go ahead, Kylie.
So just on a same note, as Daria was talking about children being separated from families, in the US, that was such, and still is such a problem, that there are laws specifically designed such that Native children are supposed to be adopted and be placed with Native families to try to keep them together. But of course, unfortunately, those laws are rarely, if ever, actually followed. But there is, and many times, legal protections that are supposed to prevent these things from happening and supposed to keep Native kids with their families. But because the system works the way it is, they're often not followed. And something else I'd like to add to that, these two kind of issues of sterilization and then also separating children from their families, both of these are criteria of the UN's definition of genocide. And so whenever we talk about like the genocide against Indigenous peoples and genocide against Native Americans in the US and Canada, we're not only talking about something that happened a long time ago. These are things that meet the definition of genocide that are happening up until right now. And that's just something that I'd like people to understand in terms of the seriousness of what we're talking about.
Thank you. Yeah, and another question, going off of like these institutions of healthcare that affect Indigenous populations and Native Americans, could you briefly describe the structure and the effectiveness of the Indian health services, and what are its flaws and benefits. And the IHS is in the United States, but Daria, if you could also speak to, I don't know what the IHS is in Canada, but if you could also talk about that, that would be wonderful. And this is open for anyone to jump in.
Thank you, Rayma. I would say today over 2.2 million Native Americans across the country rely on healthcare provided by the IHS. Accessibility and free healthcare fulfills treaty responsibilities to provide care for members of more than one, as I mentioned before, 560 recognized tribes in the United States. And year by year, Congress has consistently underfunded the Indian Health Service, forcing hospital administrators to limit the services offered. Something so small as acquiring funding to create more parking spaces literally requires an act of Congress. As a result, for example, to match the level of care provided to the federal US prisoners funding would have to nearly double. And this is from a study by the National Congress of American Indians. Funding would need to be even higher to match the benefits guaranteed by programs like Medicaid. According to findings by a poll by NPR, the Robert Wood Johnson Foundation and Harvard School T.H. Chan School of Public Health, about a quarter of Indigenous peoples reported experiencing discrimination, like I mentioned earlier. And it's really sad because you think about a lot of Indigenous people that are afraid to go to the doctor. They actually are afraid to go to the doctor because of the care that they receive. And I know that there was the issue with the healthcare in Canada, you know, with a Native American lady that went in there to get help and didn't get the help that she needed. And that was just, you know, a horrible experience. And you have to really think about a lot of the Native Americans that go in to just get, you know, the healthcare that they need, and they can be afraid. They can be afraid to go in to see the doctor. Sometimes you go into the emergency rooms and you are sitting there for hours. You can be sitting there for like 8 hours just waiting to get care in the emergency room, which is just really sad. But there's just a lot of issues at the Indian Health Services and a lot of changes that need to be made, you know, to make the healthcare center, you know, the healthcare better for Indigenous people across the United States and Canada as well.
Thank you. Does anyone else have anything to add?
Our healthcare system, I suppose, is very different. I should get myself familiar to yours, but I think it's different. We have, I think, 10 provinces and 3 territories, which are responsible for their own healthcare. So, I mean, Ontario and the government of Ontario are responsible to provide, you know, publicly funded healthcare for me and other people. But it is different for the whole of Canada for specific populations, Indigenous population, veterans, militaries, immigrants, and migrants. I mean, I think they're trying to include migrants and refugees. So the separate very distinct populations are only covered by the federal government, and so that include Indigenous people. I would like you guys to check online if Métis people are included, or healthcare is funded by the government, because quite often those people are not, are basically excluded, and they can't really fit in, you know, one or the other, provincial or federal. So it's very complicated. So what did I say? So healthcare covered by the federal government, as well as a few other programs that are in place to sort of catch people that are falling between the cracks, like children who are non-status, for example. There have been made multiple incidents over the years where a child would die because it becomes an issue of who's paying for, their travel, and or who's going to pay for their reassessment. They have to be flown into, I don't know, Winnipeg, which is, the capital of Manitoba. And so the kid misses care, very important health care, because, the government says that it's not for them to pay. And then the province says it's not for them to pay. And families not being able to afford the care either. And so we have a principle that you can read more about. It's called Jordan's principle here in Canada, to try to help children access better health care. And it's basically allows for nobody to say ever that, a child wouldn't receive healthcare services or social services as well. It includes pathology, speech language pathology, occupational therapy, anything really that child and the family might need for their well-being. We also have I know all the acronyms, and I have to think about the actual names. Let me think about it. The non-insured health benefit, and that would allow me, for example, to ensure that a patient is able to access care off reserve for a predetermined length of time by a specific healthcare provider, kind of thing. So it's still very, very restrictive, but we have that. And depending on which government is in power, those who are able to lobby would sort of push and demand for reforms of these programs. Yeah, so basically, briefly, that's what we have under the federal government. And it's called the Indigenous ISC, Indigenous Services Canada.
Okay, awesome. Thank you guys so much for sharing that information. So we will now move on to the next big topic, non-communicable diseases. And this section will be moderated by the NUGHI Social and Service Chair, Becky. So Becky, go ahead.
Thanks, Armia. So we're going to dive into talking about non-communicable diseases. And one of our first questions is, we'd like to hear more about some of the most common health issues that you see in your work. We have heard from you guys throughout this panel about some of the common ones, but thinking about non-communicable diseases, we'd like to hear more about those. And Dara, if you'd like to go first.
Non-communicable diseases, I don't have any actual data to share, but it's very clear for me, looking after the health of non-Indigenous and also Indigenous folks, that it's more prevalent within Indigenous communities, and worse when they are further isolated, in remote part of the country. And I noticed a lot, well, I don't notice a lot, there is for sure a lot more diabetes, cardiovascular illness, mainly hypertension. I don't see a lot of hyperlipidemia, but that's most likely because we do not have readily available testings. So it's easier for me to diagnose diabetes than it is to diagnose anything else. There is also a high rate of cancers. I personally worked more with women when it came to cancer screening. So I can for sure say that there is a high rate of cervical, ovarian, breast cancers among Indigenous people, women. And it's, that's one thing for cancer. And I see a lot of skin disease disorders as well, not like infectious skin types are more like inflammatory diseases of the skin, and anything basically related to lack of safe water.
Thank you. Does anyone else on the panel have anything they want to share on that?
Sure, I could just add a little with chronic illness due to environment, addiction, which is due to a lack of resources, and I would argue intergenerational trauma that extends into the genocidal acts that began in 1492 and continued into the 1970s when Indigenous women were being sterilized without their knowledge or after being coerced by their doctors. So, you know, we talk a lot about the sterilization of women, unfortunately, but that is definitely a big part.
Thank you, Rexine. Sorry, my audio might be a little bit fuzzy, but the next topic that we wanted to dive into is mental health resources, what you experience the most in your work. So just want to open up the floor if anyone has insights on how mental health they've seen in their work with the Indigenous populations.
I can go. Well, I think, okay, let me just say this. A lot of what we do in healthcare lacks culturally safe, what's the proper word? Maybe culturally sensitive, safe, basically, care. And a huge lack of awareness of, you know, anything that's not Western. So, and that's a huge barrier for a lot of Indigenous patients I have to accessing care. And so imagine what it is for what it would be like for mental health. The way that we view life in Western culture is completely different. It's different to the way that Indigenous people do view life and value community, family, and how we support each other. Like I found that, and it's, you know, I'm also seeing Indigenous people. There are many communities, different cultures, and you know the way that I would approach patients in the James Bay area will be very different that I would approach the people, they're Dene people in northern Manitoba, because they're different cultures. So what we tend to do in Western medicine is to not really listen to the person coming to you for help and provide what we think we know they need per our books. And that's one huge problem when it comes to mental health. And now there is more push, and I shouldn't say really push, but there is a big change toward healthcare providers completing cultural safety trainings to ensure that we're properly interacting with patients and for better, you know, outcomes for folks. And there is also a lot of talks and less doing, but you know, we have to start somewhere. So it talks about community-centered care and advocating for community members to offer mental health services, for example. Like I have lived on reserve, but I left. So when I leave, who is doing it? And I was there for a while, but most places I worked had healthcare providers are there for a couple of days and they're out. Like what happens to a 17-year-old boy who's being bullied when the healthcare provider is gone? What happens to the kid and their families when you know, the internet is cut off and then we cannot do virtual psychiatric canceling anything. So anyways, I think I've been talking a lot about challenges in my practice, but basically that's the state of it. It's very, very challenging. But now I love that more community members are being involved in the care, and so they're there and they're being supported, and so they're not burden. It's also hard, right, to be at home full time and being the only person and then not being supported by the healthcare system. But so I'm seeing some change, at least in the parts where I've been working at.
Thank you for sharing the challenges. I know it's hard, but it's good to hear that there are some improvements. Kylie, I see you unmuted.
Yeah, something I could add in the area of mental health. I think this is one of the areas. Daria mentioned a lot of the challenges on reservations of not having enough resources. And I think mental health is also a challenge for urban natives as well. And I think that's something that we need to kind of keep in mind, because as difficult as it is to get resources on the reservations, when you think about all of the natives who are living away from the reservations as well, lots of times we struggle being far away from our home, far away from our traditions. And for us, maybe we get to go home once or twice a year for one of the big ceremonies or something like that. And especially years like this year, we might not be able to do that because of the pandemic. And so that's another area where mental health is not really supporting natives as well as it could, because if I look for a therapist, it's going to be very hard for me to find one who is actually versed in my culture and knows and is aware of my traditions. And so I think for a lot of us who are away from the reservations, being able to go home and being able to immerse ourselves again in those traditions is some of our mental health care. And so I think it would help for both urban natives and the natives living on the reservations if Western medicine and Western therapy could maybe, as Daria said, be more, not only be more culturally sensitive, but also maybe try to incorporate more of our traditions and our traditional ways of knowing and ways of healing. I think a lot of times as natives, we really need some of that as well, some of that tradition to be mentally healthy.
Thank you so much to both of you. Cultural insensitivity is a big part of our third topic, but we had one last question about non-communicable diseases, and that was about food insecurity. So in general, in your guys' line of work, I know it's hard to kind of answer this question based on all of the different reservations in the United States and in Canada, but what would you say is like the average proximity of grocery stores with fresh produce and healthy foods to a Native American or an Indigenous person living on a reservation? And how does access to these type of stores affect food insecurity and rates of other non-communicable diseases such as diabetes and heart disease?
Hi, Rema again. So the Navajo Nation has the same landmass as West Virginia, but only 13 grocery stores, and the lack of electricity access further complicates food access. One of the biggest health threats to the Navajo people, besides exposure to toxic mining, is diabetes, whose management depends largely on access to fresh food, which normally depends on access to refrigerators, which depends on access to electricity. And the average person drives 3 hours to buy food and hauls water from wells that can take an entire day to get to. This all can seem impossible to imagine for many people. So I would probably ask you how much of your health depends on access to a grocery store? How much of your household's health depends on the availability of electricity that can power a refrigerator? Today as well, we're trying to hyper manage hygiene. how much of your household's ability to remain safe from COVID-19 depends on the presence of running water. And I know that we're going to talk more about COVID-19 and all of that, but right now it's just really come to the surface, really focus. We're seeing how the communities on the Navajo Nation are affected so much by COVID-19 because they don't have running water. They don't have the water to wash their hands. We have a whole family where we are, they're sharing one bowl of water to conserve water, and they're sharing that in their homes. And just today, I'm on the shift where I'm working with a group of individuals, the contact tracers, where we're trying to figure out how to get water to these individuals. There's a family out there, we're asking them to isolate or quarantine, and they have no access to water. They're stuck at home because we're telling them to stay at home and they don't have running water. So we're trying to do our best to try to get water to them. And fortunately, there's some really wonderful grassroots organizations that are working with them now, trying to deliver water out to them so that, they have more water so that they're able to wash their hands, as they need to during this really difficult time with COVID. But, hopefully these are issues that can be, worked on quickly, even as, hopefully when the pandemic, goes away soon, hopefully we can help these families so they have access to running water in their homes.
Thank you so much, Rexine. Does anyone else have anything else to add to that before we go on to our last topic? Okay, so the last topic is Indigenous populations' relationship with Western medicine, and also kind of looking at COVID-19 and possible treatments. So Jenny is going to moderate this this section with me. So Jenny, go ahead.
Hi guys. So kind of going off of what was discussed earlier in the non-communicable diseases questions, in terms of, finding healthcare providers that are well versed in their culture and being sensitive to their culture. And there are cultures that are being mixed here in this process, and how receptive is the Navajo Nation to Western medicine being introduced to them, especially in consideration of like bioterrorism and genocidal tactics used by the US in the past. Like, would the Navajo Nation be open to a vaccine? Or how do healthcare workers compromise with, if there is any resistance, how do they compromise with the resistance that they might face?
So every effort of the cultural translation needs to be guided by the patients and the community. In the COPE program and the PIH program that I work with, our contact tracers, our efforts are at the recruitment. Our efforts as we recruit have brought us to callers that are Navajo University students, Navajo professionals, and retired Navajo health practitioners. They have firsthand and secondhand familiarity with the chronic illness due to cancerous and respiratory illnesses caused by uranium and coal mining. They are young students who ask our trainers and team leaders about how to ask for our patient's gender identity with respect. Are you male or are you female? Has become to asking the question, what is your gender identity? Our program relies greatly on the development sessions in which we invite professionals to instruct our callers. One of the best ways to this input has appeared in our contact tracing programs was by a Navajo mental health practitioner who told us to ask questions regarding symptoms of COVID-19 in third person. Instead of saying, do you have a fever, which can frighten traditional Navajo people, because speaking this way invites a fever, we ask in third person. So we say something like, a person with symptoms of COVID-19 might experience a fever. Is this something you may have experienced? In some way or another, the professional diversity of our callers makes our program more successful every day. As Indigenous health workers, I have to say the best thing you can do to serve Indigenous communities is to make sure that Indigenous peoples are in the room where decisions are being made, center Indigenous voices, pass the mic, find ways to move Indigenous peoples into decision-making positions.
Thank you, Rexine. And the question had originally specified Navajo Nation, but Daria, if you could speak about any of the Indigenous communities that you've treated in Canada, and also Kylie, if you have anything to add about the Zuni tribe, feel free.
As a non-Indigenous practitioner on Indigenous land, within Indigenous communities, my approach is always to present, the medicine that I have, pharmacology. Geez, I forgot that word. And everything, vaccines, and keeping in mind the history of colonization and the ways that diseases came to be on this part of the world, and being mindful of people choices to refuse care as well. And so I don't impose care. I presented the way I learned, which is Western. But I also recognize the traditional medicine and traditional ways of looking after your health from the Indigenous communities. So I always involve community health workers, and especially for teaching. So if there is an outbreak of syphilis, for example, and and we need to manage that. So then whatever teaching tools we have, like infographics or whatever, we try to find some that makes sense to the community, for the language and also the image. There have been a few instances where I'll be trying to explain a medication to a patient, but the wording does not make sense, so then somebody from the community has to help me properly explain what is it that I'm trying to do and why. And also keeping in mind, what is life for other people, like, maybe their choice is to simply be and continue their life. And our focus in Western medicine is like basically stopping death and whatever it is our goal is, and that's not necessarily what the other people goal with staying healthy is. So yeah, I guess in short, cultural safety, sensitivity, and including local healthcare workers and recognizing their skills, knowledge, and everything else that's not similar to what we learn in school.
Thank you. Oh yeah, Kylie, go ahead.
So over the last summer, I think a lot of our communities have had to learn some very difficult and challenging lessons in terms of what COVID-19 is costing us. And certainly I think a lot of the people who were more resistant to why we had to do certain things a certain way are becoming more amenable to our curfews and wearing a masks and staying isolated and things like that. And after we saw family members getting sick and community members getting sick and all of that, I wish we could have taught people better on how to avoid those things before that happened. But at this point, at least in Zuni, we, the elders and the religious leaders are helping to inform the people on how to stay safe. And things were harder earlier in the summer. With the religious ceremonies, lots of people are very traditional, and lots of ceremonies involve a lot of people that in a way that is not socially distanced. And it's very hard to try to convince people to not do those at all, or to reschedule them or do them in a different way. And so things happen. For example, one of my uncles tested positive and exposed my family members, my grandmother's household. Fortunately, my grandmother's household was okay after that, but these things happened, and now the religious leaders and the elders are helping to inform people in Zuni and Shiwitma, and in English, in different languages, to how to stay safe. And I think in Zuni, the Pueblo has been closed to outsiders now, so non-Zunis can no longer visit. I think many of the other Pueblos have also followed that, and I think our numbers in terms of new cases have finally started to go down rather dramatically. So it seems to be helping and seems to be improving, at least in the past few days from what I've looked at in terms of the latest numbers. So I'm hopeful in terms of how things are going forward. I was very scared over the summer, and I'm still very worried, but I think we're learning, and with the elders and religious leaders helping, and I think things are going to get better.
Thank you guys so much for your input. And I think this might be our last question. But so the United States in general does not have great rates of health literacy in its population. And I was wondering if you guys could speak briefly about the status of health literacy in Native American and Indigenous populations, and how access to Wi-Fi and technology in general might affect this. We spoke about access to Wi-Fi a little bit earlier, but yeah, Rexine, go ahead.
Sure, thank you. As I said before, I work as a lead trainer with contact tracing across the Navajo Nation, and access to electricity is a hurdle. How do you change a phone, for example, or charge a phone? How can you ask for emergency assistance when you are not in a service area? Or how can you answer daily calls from contact tracers to monitor your health without electricity or reception? My own parents are pretty modern people, but they are elderly, so they have trouble answering phone calls with their smartphones. But we've definitely found this to be a big issue on the Navajo Nation, even with our volunteers, those contact tracers that are taking the time to volunteer and call out to the patients that need to be contacted, the contacts of the cases. They struggle with electricity, or they struggle with good Wi-Fi service. So it's kind of hard for them to join our shift huddles daily, or they can't complete the work that they need to complete because they just don't have good Wi-Fi service. So that's been a big impact on the work that we do as contact tracers.
Thank you, Rexine. Does anyone else have anything to add?
Just in terms of Wi-Fi and internet access, one thing I've noticed in terms of my own communities, I think there are a lot of smartphones, but there aren't as many computers. And so I have most of my cousins, but also a lot of my older relatives are on Facebook, for example, on their smartphones, but don't have a home computer or even home Wi-Fi. And so for example, tribal gossip will travel very quickly on Facebook. But I think one thing that's important is trying to use that mobile technology. People might not be able to access traditional websites as easily as they might things that are more mobile friendly. Because even though there's still a difficulty in having access to smartphones and things like that. But I think I've certainly seen a lot of people who have those things, but not a home computer or home Wi-Fi or things like that.
Thank you, Kylie.
The only thing I can add is that literacy is a challenge period because of the legacy of colonization in this country, talking about Canada. And so, if it is a challenge to bring teachers in communities to, for basic knowledge or maintaining some form of education system within communities, then just imagine how it is for health literacy. But health authorities combined with the federal government and nursing associations or medical associations are becoming more intelligent in ways to approach the challenge when it comes to health literacy, and looking into creating better infographics and having town meetings involving members of the community health worker and members, and having locals transfer the knowledge rather than continuing the way we learn health literacy, which is not very inclusive. And so that's going on. People are coming together and working together, but we do also have the challenge of not having access to reliable electricity, internet. Most of the places I work at, I don't have cell phone reception. So, like if I need to show a picture of something to describe, a skin disease, I'm limited, So, yeah, it's a big challenge, but we're getting there slowly. Things are improving, and we do have some communities now, depending on the province, are getting funding to better utilize what is OTN. It's telemedicine basically. So we're using telemedicine to better facilitate the provision of healthcare within certain communities. Then again, Wi-Fi goes out, electricity goes off, and then we're back to square one. And yeah.
Thank you all so much for your answer to that question, as well as your input this evening on this panel. So those were all of our questions, and your answers were very informational and insightful, and we learned so much from all of you. So thank you. And we're going to open it up to audience questions. And if you guys have a question, you can unmute yourself and ask it, or you can also put it in the chat and then I can read it out loud. But yeah, does anyone have any questions? Okay. So there's one question. How can we productively be a part of the movement to improve statuses of Indigenous health? Does anyone have anything to add?
I forgot to unmute myself, so anybody can go first.
I guess one thing I would say is pressure your local and national politicians to provide more funding for Native health services and COVID relief and all of those. We were supposed to get a lot of funding for COVID, but we've only started to actually get some of that. It took a long time, and I don't know if we've actually gotten all of it yet or not.
Thank you, Kylie. Does anyone else have anything to add?
I think just as I said earlier, just really centering the Indigenous voices and passing the mic, finding ways to move Indigenous peoples into decision-making positions, just really listening to them, I think is a really big part of it.
I totally agree with both Kylie and Rexine, and I would say lobbying your local government over your healthcare system is governed locally, federally, or provincially. I guess for you guys, it's states. And also getting yourself educated, expanding your circle of educators, not sticking to what your school provides, but looking around, reaching out to communities as an ally or an outsider or whatever, but just, doing your best. And the research that you do conduct within your department and schools, and making sure that there are researches that matter to the people you're trying to help, and really bringing forward their issues rather than what we think are the problems. And, when you become physicians or nurses or whatever, help the people, use your skills to improve our healthcare systems wherever you find yourself professionally, or as a volunteer. Honestly, you can give a lot of your time to many causes as a volunteer as well.
Thank you so much for your answers. Does anyone else have any other questions? Okay. If not, we did go a little bit over the time. So thank you guys for staying with us. And yeah, thank you so much to everyone who attended. And again, thank you to the speakers. Happy Indigenous Peoples Day, one day late. It was yesterday, but we're celebrating today with this panel. So thank you guys. Hope you have a great rest of your evening. Yeah, I will go ahead and Becky, you can go ahead and stop recording.